Hey everyone! Today, we need to talk about something that happened over the weekend that should concern every person who remembers what pandemic fear actually feels like. So imagine this with me. A surgeon wakes up Saturday morning in a remote hospital in the Democratic Republic of Congo. He's the only surgeon serving the entire region. By Saturday evening, he has a fever. By Monday, he gets the test results. Ebola. Not just any Ebola. The strain we don't have a vaccine for. The strain we can't treat. The strain that kills up to half the people it infects. His name is Dr. Peter Stafford. He's American, 41 years old. He has a wife who's also a doctor, 4 young children. And by Wednesday, the World Health Organization had declared a global health emergency. But here's what nobody is connecting yet. There's one number buried in this story that changes everything. By the end of this video, you're going to see exactly why epidemiologists are using words like catastrophic behind closed doors. Now, you might say, I don't live in Central Africa. Well, the virus doesn't care about borders. So hit that subscribe button because this one goes deep. Let's get into it. So here's what happened. May 5th, the WHO gets an alert about mysterious deaths in Mongwalu, eastern Congo. Health workers are dying. They run standard Ebola tests, negative. But people keep dying. May 14th, 9 days later, the lab runs a different test. 8 out of 13 samples positive, not for the common Ebola strain. For Bundibugyo virus, only the 3rd outbreak of this strain in history. May 15th, Congo declares its 17th Ebola outbreak. The numbers are staggering. 336 suspected cases, 88 deaths. Cases in Uganda's capital. Cases in Kinshasa over 1,000 kilometers away. May 17th, the WHO declares a public health emergency of international concern. The same designation given to COVID-19. May 18th, Dr. Peter Stafford tests positive. First confirmed American case. The CDC announces travel bans. Stafford, his wife, their 4 kids evacuated to Germany, not the United States. Germany. Because bringing a virus with no treatment onto U.S. soil is too risky. This entire sequence happened in 12 days. Compare that to COVID, which took weeks. The speed tells you something. The experts aren't waiting to see how bad this gets. They already know. Now here's why this outbreak is different. Most people hear Ebola and think 2014. 11,000 dead across West Africa. That was Zaire Ebola, the most common strain, fatality rate up to 90%. But we have vaccines for it now. We have treatments, monoclonal antibodies. The 2018 Congo outbreak was contained because responders could vaccinate people, create immunity rings, treat patients with antivirals. None of that exists for Bundibugyo. No licensed vaccine. No approved treatment. The only tool doctors have is supportive care. Fluids, oxygen, hope. The fatality rate is 30 to 50%. A coin flip with slightly worse odds. And the healthcare system in Ituri province is beyond overwhelmed. Hospitals in Bunia ran out of space days ago. Field hospitals are being set up. Médecins Sans Frontières is mobilizing teams. But the region is one of the hardest places on Earth to operate. Poor infrastructure, armed conflict, high mobility. 2 million people already displaced. Dr. Trish Newport from MSF said it plainly. The number of cases and deaths in such a short time frame, combined with spread across health zones and borders, is extremely concerning. That's not managing a contained situation. That's watching a fire spread faster than responders can move. But here's where it gets worse. The official count as of May 19th is 543 suspected cases, 131 deaths. But epidemiologists believe the real number is far higher. Why? The outbreak likely started weeks before detection. The first case showed symptoms, April 24th. Died 3 days later. WHO wasn't alerted until May 5th. First positive test, May 14th. That's 20 days between first case and confirmation. 20 days of undetected spread. And here's the kicker. Initial tests came back negative. They were using tools for Zaire Ebola, not Bundibugyo. Infected people were sent home, told they didn't have Ebola, then spread it to families. By the time correct tests were run, hundreds exposed. Contact tracers are trying to track everyone. But in a region where people move constantly, where informal healthcare is the norm, where trust in government is low from decades of conflict, it's nearly impossible. One epidemiologist who worked the 2014 outbreak called this a nightmare scenario. High transmissibility, no vaccine, delayed detection, cross-border spread, traumatized population with every reason not to trust outsiders in hazmat suits. And healthcare workers are dying. At least 4 dead. When healthcare workers die, you lose defenders and everyone else gets scared. If you're a nurse who watched 4 colleagues die from a virus you can't protect against, do you keep showing up? That's playing out across Ituri now. Now let's talk about borders. Uganda confirmed 2 cases May 15th to 16th. Both traveled from Congo to Kampala, capital city, 1.5 million people. 1 dead. The virus is now in an urban center with international airports, dense population. Kinshasa, Congo's capital, 15 million people, reported a suspected case. Tested negative, but the fact someone symptomatic traveled 1,000 kilometers shows how mobile this population is. Mobility is the virus's best friend. WHO is working with Rwanda, South Sudan, Burundi, Tanzania on border screening, isolation wards, contact tracing. But Central African borders are porous. People cross daily for work, trade, family. You can't lock down this region without causing humanitarian catastrophe worse than the outbreak. The US CDC mobilized its Ebola team. May 18th, travel restrictions via Title 42. Non-US passport holders from DRC, Uganda, South Sudan in past 21 days barred from entry. Enhanced screening for returning Americans. European CDC sending experts. African CDC deploying teams. WHO activated emergency operations. All of this costs enormous money. The 2014 outbreak cost $53 billion in economic impact. This time, no vaccine coming, no treatment pipeline, only containment. And containment in a conflict zone with limited infrastructure is extraordinarily expensive and difficult. And here's the number I mentioned at the beginning. 543 suspected cases in 3 weeks. But the outbreak was spreading 3 weeks before that. 6 weeks of transmission. In epidemiology, there's doubling time how long for cases to double. Early reports suggest 7 to 10 days. Do the math. 1 case April 24th, doubling every 7 days, you'd have 16 cases by today. We have 543, which means either it started much earlier or multiple spillover events from animals, or it's spreading faster than models predicted. Epidemiologists believe all three. One Imperial College researcher told colleagues the real count could be thousands, not hundreds. For every confirmed case, 5 to 10 unconfirmed cases circulating. People symptomatic but untested. People pre-symptomatic who don't know. People too scared to go to the hospital because everyone at the Ebola ward dies. With 35% fatality rate, more than 1 in 3 infected aren't coming home. This is the reality, and nobody in leadership wants to say it publicly yet. But this isn't just numbers. Dr. Peter Stafford didn't go to Congo for money. Missionary doctors don't make Wall Street salaries. He went to serve forgotten communities. He was the only surgeon at Nyankunda Hospital, only surgeon for hundreds of thousands of people. Emergency surgery, C-sections, burns, he was the only option. And he stayed when the outbreak started. When others evacuated, he stayed because his patients had nowhere else to go. His wife, Dr. Rebecca, an OBGYN, delivering babies in a region with the world's highest maternal mortality. All 3 doctors followed every protocol, wore every protective equipment. And Dr. Stafford still got infected. 1 moment of exposure, 1 microscopic breach, 1 drop of fluid. Nancy Wrightbull, who survived Ebola in 2014, described the guilt of evacuation while the people you serve die with no treatment, the fear that haunts you even after recovery. The Stafford family is living that nightmare. He's in isolation in Germany. His wife and kids in quarantine, terrified. And back at Nyankunda, the only surgeon in the region is gone. Patients are on their own. And what are leaders actually doing? WHO declared a global emergency. Right move. But declarations don't stop outbreaks. Resources do. The 2014 outbreak required over $3 billion in emergency funding. This outbreak, worse infrastructure, conflict zone, no vaccine will cost more. Right now, pledges trickle in slowly. US committed CDC personnel but no financial specifics. EU pledged assistance, details vague. African Union coordinating, but many facing their own crises. Then there's the political reality. The Trump administration cut funding to global health programs in its first budget. USAID pandemic preparedness slashed. CDC international surveillance lost funding. The infrastructure for early detection was gutted. Grace Tran, former USAID Ebola responder, said it plainly. The earliest cases went undetected. They didn't test for this strain. It could have been spreading for weeks. Response is complicated, requires training. That funding disappeared last year. That's not speculation. It's documented fact. Now we're watching consequences in real time. Delayed detection, overwhelmed systems, responders scrambling for resources that should have been in place, and a virus spreading faster than the response can keep up. But this isn't just about Congo. It's about you. Infectious diseases don't respect borders. The same mobility that spread Ebola from Ituri to Kampala in days connects Africa to Europe, Europe to North America, North America to Asia. You can board a plane in Kinshasa, land in Paris in 8 hours, fly Paris to New York in 7. If you board during incubation, before symptoms, before anyone knows you're infected, you carry the virus with you. That's how outbreaks become pandemics. COVID started as pneumonia cases in Wuhan, December 2019. By January 2020, it was in the US. By March, global lockdown. Ebola isn't COVID. It doesn't spread through air. You can't catch it walking past someone. You need direct contact with bodily fluids from symptomatic people. Harder to spread, but more terrifying when exposed. COVID fatality rate around 1%. Bundibugyo Ebola 30 to 50%. If you get infected, odds of dying worse than a coin flip. No vaccine to protect you, no treatment to save you, just supportive care and hope. So when CDC says risk to Americans is low, they're technically correct. No confirmed US cases, no local transmission, travel restrictions in place. But low risk isn't zero risk. And low risk today becomes high risk tomorrow if Central Africa outbreak grows unchecked. Every day without containment is another day for the virus to spread, reach transportation hubs, board international flights. Epidemiologists aren't panicking, but they're not relaxed. They're watching, waiting, running models, hoping response moves fast enough. All right, let's bring this back. Dr. Peter Stafford woke up Saturday with a fever. By Monday, Ebola. By Wednesday, global health emergency. 543 suspected cases in 3 weeks. 131 deaths. No vaccine. No treatment. A virus spreading in one of Earth's most challenging regions. And a global response racing against time to prevent something far worse. Here's the bottom line. This outbreak is not under control. Cases rising faster than contact tracing can keep up. Healthcare system in Ituri collapsing. Virus crossed international borders. And the tools we used before, vaccines, treatments, rapid diagnostics, don't exist for this strain. What happens next depends on whether the international community moves fast enough with enough resources to contain this before it spirals. If they do, this outbreak gets controlled, case count peaks, becomes another footnote in Ebola history. If they don't, we're looking at a regional epidemic spreading to dozens of countries, killing thousands, maybe more. The difference between those outcomes is measured in days, not weeks. Every delay in funding, personnel deployment, isolation ward setup, contact tracing gives the virus more time. And Bundibugyo is not patient. So I want to hear from you in the comments. Do you think the world learned enough from COVID to respond faster? Or are we watching the same mistakes again? If this video opened your eyes to what's happening in Central Africa, hit that like button. Subscribe to the channel for more deep dives into stories that affect your future. Hit that notification bell so you don't miss what's next. Stay informed, stay engaged, and never stop asking questions. See you in the next one.